Dear friends, today we are going to talk about an important topic, that is cystic fibrosis. Sometime before, we all thought it is a rare disease, common only in Western Europe. But after the advent of investigations, we are able to diagnose this problem throughout the world. Moreover, the treatment aspects of cystic fibrosis is drastically changed, increasing the life expectancy of persons who suffer cystic fibrosis. Since it's a very vast subject, I thought we can divide the subject into symptoms, that is part 1, diagnosis, that is part 2, and a treatment, that is part 3, so that people who are interested only in diagnosis can read the second topic, or the people who are interested only in the treatment go for straight away part 3, that is the treatment. Cystic fibrosis, it is an autosomal recessive disease and it is a multi-system disease, and it is because of the defective gene. It is called CFTR gene. It is a single or monomutational disease, and the gene is situated on the long of the 7th chromosome, and this cystic fibrosis transmembrane conductance regulator gene, that is a full name for the gene. It encodes chloride channel. We all know chloride plays a very, very important role, especially in the regulation or rheology of the secretions. And when this gene goes mutation, there is a problem. Of late, roughly 2000 or nearing 2500 mutations have been diagnosed, and the most common is delta F508 mutation. Right. Then what is happening when the mutation, that is cystic fibrosis transmembrane regulator gene mutation, happens? Because of the defective CFTR gene, the proteins formed are also defective, so that the chloride transfer also become problem. The chloride is not coming out of the cell, so naturally sodium also doesn't come out of the cell, and naturally then the secretions become thick, because when sodium and chloride is not coming, water also stays with that, so that the secretions are becoming very thick, sticky, and they in fact obstruct the ductules and ducts. So all the intestinal glands are get clogged up, and this is more prominent in pancreas, respiratory system, and reproductive system and all. Can you see this? This is a chloride channel that is situated on the luminal surface of the epithelial cells, and this is that actually this is a diagram done by Rockefeller University. It is this defective, this is a protein that forms the chloride channel, and that is responsible for, actually this protein is made up of a domain of 1480 amino acids. So I said the secretions become thick, so the pancreatic duct obstruction occurs. That is mostly in severe mutation, that pancreatic insufficiency or pancreatic duct obstruction is occurs early. Then the respiratory system suffers, because we all know it is we got a very nice mucociliary transport mechanism, and that is the one that responsible for removing the infectious and non-infectious particles from lower part of the lung, and that is also impaired, and again reproductive system also get impaired. This is what I have been telling sometime before. We thought the disease is only in Europe. Now look at the brown and red. It has been there throughout the world, including India, including China, including Japan, and African countries. That if at all anything is less, is only in the African countries. And again, what they say, even if there is a cystic fibrosis, we hardly diagnose only 64%. So majority is not diagnosed. That is also a problem. These are the manifestations of or the clinical presentations of cystic fibrosis. Is a very vast problem. See, even mugging up all this is very, very difficult. It manifests in infants, and it manifests in childhood, it manifests in adolescence. It all depends upon the type of mutation. And anything that manifests very early is a real problem. And anyway, I am going to talk about this in the form of some clinical cases. I am going to show 4 cases. The first case is happened at infancy. The second one is the most typical presentation of cystic fibrosis. Third one is again it is a lethal presentation of cystic fibrosis happened in the newborn. Then this presentation happened in the adult. Now let us start with the first case. This is a 4-month-old. I am not going to read everything. That is very difficult. Time consuming. It is a 4-month-old baby presenting with a cough, failure to thrive, admitted 2 times, and look at the X-rays. They made a diagnosis of recurrent pneumonia. See, look at the pneumonia is there in the right lower lobe and multilobar pneumonia. So that is a presentation for which the child got admitted. Then they requested for a ball. Naturally, we are not going left out with any other investigation. So we all have a combined discussion to go for a ball. Ball means bronchoalveolar lavage. Okay, we have done bronchoalveolar lavage. The bronchoalveolar lavage demonstrated Pseudomonas. Whenever there is a Pseudomonas in any respiratory specimen, you have to think of cystic fibrosis. That is what the usual message. Okay, so immediately we have done sweat chloride, and we made a diagnosis of cystic fibrosis, and later your genetic studies proved to be delta F508 mutation. Some organisms are very typical. That is why they are called signature organisms. That is maybe if postgraduates, it is a real short notes for you. Some organisms are called signature organisms because if you isolate these organisms in the respiratory specimen, maybe a sputum or induced sputum or BAL, and you have to think of the possible underlying disease, of which one of them is Pseudomonas. Pseudomonas means you always rule out cystic fibrosis. Staphylococcus typically go with chronic granulomatous disease, but it's also present in some other condition also. I will come little later. It's a capsulated organism. Even in complement deficiency it may happen. Aspergillosis, actually if you isolate aspergillosis in respiratory specimen, particularly ball, it is diagnostic because this organism Aspergillus vivacius is always wants to reside in the lung, and the condition may be some sort of immunodeficiency like hyper IgM syndrome. And again pneumocystis jirovecii, this also similar. These are the organisms are most notoriously want to be there in the lung, and it shows there is a possibility of underlying T cell immunodeficiency. Coming to the conditions with a higher risk for bronchiectasis, which are the condition when you happen to treat, there is a possibility of such condition going as a complication of bronchiectasis. Number 1, cystic fibrosis or any immunodeficiency or primary ciliary dyskinesia, repeated aspiration, connective tissue disease, or even ABBA. Why I have put all these things is CC and all. It is something like a mnemonics for you. So which are the condition or higher risk for bronch? You can easily remember. See, cystic fibrosis, congenital immunodeficiency, ciliary dyskinesia, chronic pulmonary aspiration, like that, connective tissue disease. You can very easily. That's the reason why I put with some change, and these are the condition typically go for bronchiectasis. Actually, bronchiectasis is considered to be a really last or end stage of the respiratory problem. But anyway, we are going to talk about that little later in the one of the slides. Coming to the second child, it is a 7-year-old child presenting with a chronic wet cough, productive cough with excessive sputum in the morning, failure to thrive, clubbing is there. Can you see that clubbing? Digital clubbing. She also had halitosis, and there is some sibling death in the family and all. So this is a bronchiectasis proved by both X-ray. You can X-ray showing bronchiectasis on the left lower lobe, and also something happening on the right lower lobe that has been pictured in the CT. So this child typically having steatorrhea, greasy stools, bronchiectasis. What else you want? When you have this combination, steatorrhea or bronchiectasis together, you have to suspect or we have to rule out cystic fibrosis. Set fluoride is done because there are many centers, they now doing iontophoretic technique. If initially they thought it is a really bad investment, that is the reason why nowadays many medical colleges they are keeping this this is a iontophoretic technique, so that can make a diagnosis very easy. So sweat fluoride is 72. Then with a background of clinical picture, the child was diagnosed as cystic fibrosis. Now we started the treatment. You can ask me how or why bronchiectasis is happening in cystic fibrosis. I already said, look at the mucociliary transporter mechanism. Can you see that? This is what happening in the respiratory mucosa or in the airway. So inner sal and outer gel layer, and any particles coming down is being sticking on to that, and by nicely, because of the movement of the cilia, it goes up. We either expectorated or coughed out, and that is what the children may say plum. So this gentle mechanism or the beautiful mechanism is failed or compromised or impaired in cystic fibrosis. That is the reason why instead of this normal mechanism, the secretions here, inner gel and outer sal layer become very, very thick, that prevent the movement of cilia. So thick secretion, defective mucociliary transport, excessive, so it all causes backlog or accumulation of mucus. Whenever there is a mucus is a good nidus for bacteria. So it favors the growth of bacteria, and even some of the bacteria that has been gone into the lung, that is not pushed out. See, remember, we produce roughly 1 liter of mucus per day. That is what our respiratory system, and everything get impaired. So naturally, looking at the bacteria, neutrophil infiltration occurs, and there is a fight goes between these two, and there is a lot of release of enzymes like and cytokines like protease, elastase, IL-6 and IL-8, and it continues the bronchial inflammation on the respiratory mucosa, and initially it starts with damaging the epithelium, later even the cartilage or district, then it will go for a bronchiectasis. It's a beautiful diagram that has been appeared in the ERS clinical practice in 2021, and actually whole bronchiectasis pathology can be summarized in this simple diagram. Look at that airway inflammation in any form. In cystic fibrosis, because of the mucociliary impairment, or any chronic airway inflammation due to immune occurs, it may be due to immune dysregulation also. Then the mucus secretion or the mucus gets stagnates, or there is hyper secretion of mucus, then it causes disruption of the mucociliary apparatus, and this finally cause a damage. That's what I have been telling that. That's the reason why, and if you make a diagnosis of chronic suppurative lung disease, we have to protect the child from bronchiectasis. We have to protect, otherwise once the bronchiectasis occurs, is very difficult. And I am going to tell about the types of bronchiectasis in a later slide. So it is possible to prevent the bronchiectasis if you catch early in a chronic suppurative lung infection, or even in a mild cylindrical variety of bronchiectasis. This is the third child. This is a very, I said, is a little bad presentation of cystic fibrosis, and a child presenting with abdominal distension, bile state vomiting, Meconium is not passed. Naturally, we made a diagnosis of bowel obstruction. Can you see the bowel? A lot of loops, distended loops are seen, and I think background is second sib is died because of neonatal jaundice, which makes them to think of it is a possibility of cystic fibrosis. So, looking at the dilated loops, we straight away gone for that gastrographin enema. This is a gastrographin enema, and we made a diagnosis, and we are about to do for other investigation, and by the time the child got absconded, and we made a diagnosis of clinical cystic fibrosis. So, of all, for a normal digestion, our pancreatic enzymes are very, very important. Every day we produce, I am telling about the adult, roughly we produce 1.5 to 2 liters of pancreatic secretion, because it is a secretion that contains a lot of bicarbonate, alkaline pH that contain lipase, protease and amylase. These are all very, very important. Otherwise, your whole normal breakdown of fat and proteins, particularly proteins and starches and fat, has been much compromised. That is what happening with the cystic fibrosis also. Okay, this is a last scenario. Actually, it is a really subtle presentation. It's a very favorable presentation. I can say that the child is a 12-year-old being treated as an asthma. Okay, because the child used to develop a recurrent respiratory infection, some asthma, and they put him on intermittent therapy, and some diagnosis saying asthma and all. Then child came to us, but the child started developing some sort of a clubbing. Why the child should develop clubbing in asthma? And if you go into the X-rays, there are a lot of X-rays. I have shown only 1 or 2, and these are growth retarded, clubbing, lot of multilobar pneumonias, recurrent pneumonias. So that made us to think of cystic fibrosis. Then the child was subjected for sweat chloride. Sweat chloride is positive. Anything above 60 is positive, and here the child is positive for 85 milliequivalents. Then we made a diagnosis of cystic fibrosis. Then we started advising the air clearance mechanism and all. After that, even though disease was there, the child never got admitted into any hospital, and we continued the therapy for cystic fibrosis. Particularly, we concentrated on the enzymes, because the 4 enzymes, particularly we concentrate on enzymes as well as vitamins. That is a fat soluble vitamin. The child was put on fat soluble vitamins like A, D, E, K, and is also given that pancreatic replacement therapy. After that, child was literally normal. He comes for a very regular follow-up. This is one of the late presentation, one of the very good, I think this is a favorable presentation, I can say that, where the prognosis is very, very good. What they say, once you identify the cystic fibrosis, but that is what they say, you have to diagnose cystic fibrosis in the neonatal period itself. Then you can prevent the damage. Sometimes you can totally miscuss this cystic fibrosis even in adolescent. We all think cystic fibrosis is not happening at this age group and all. It's not so. Whenever there is a growth retardation or clubbing or recurrent pneumonia or any other nasal polyp, I am going to show some of the pictures, and you have to strongly suspect. At least you have to do sweat chloride, that is very freely available. So I have shown some of the clinical cases, some of them present in the infants, some of them present in the childhood, some of them present in the adolescent. Actually, severe presentations usually present very early, and invariably they present with a pancreatic as well as lung disease. You can see both of them and all, but non-severe manifestation can present only during adolescence. That is the reason why many people say that whenever you come across these are the conditions, like in adolescence, like a pancreatitis or sinusitis or infertility, all these conditions warrants cystic fibrosis to be ruled out. Why I am telling you is there are 2000 mutations have been so far diagnosed. They are all causing defective CF protein. Actually, they put in the 5 boxes. that is 5 groups, I can say that. First group, there is no protein at all. Actually this is very difficult case, because there is no synthesis of CFTR protein, we cannot do anything. It is a highly lethal form. Sometimes that proteins are produced from the nucleus and it has gone through the Golgi. There the problem occurs. That is a defective trafficking. This is a very good example. That is what happening in Delta F508, and there are some medications are available to correct here. And other things. Sometimes this this channel is, that is a chloride channel is activated by ATP. The ATP activating mechanism fails. That is what third. And the fourth one is what they say, regular there is a defective conductance because actually it's anatomically the number of proteins may be less. And the last one is the splicing defect, where there is a functional defective. So that is a 5 groups of CFTR, and this is only I want to show that any normal protein, the proteins are very important for the body, either for a production of enzyme or a channel or a repair or a growth, anything. So it is produced in the DNA, then it is copied by the messenger RNA, it go to the endosomal, that is a endosomal plasmic reticulum, then Golgi, then finally it is shaped into a good functional protein that has been properly settled in the cell to function. So that is what defective. The defect may happen in the nucleus itself, or in the trafficking, or in the functional or total amount or ATP mechanism. That's what I've been telling and all. So we can classify severe cystic fibrosis mutations into CFT, severe mutations. The first 3 mutations are considered to be severe one. The last 2, 4 and 5 are considered to be a non-severe manifestation. Actually, now the modulators, CFT modulators are available, namely correctors and potentiators. Probably this discussion I am going to make it in a treatment slide. So here I am passingly mentioned, the people now started using some drugs that corrects here, and the triple combination is available nowadays, that includes both correctors and potentiators, and thereby though it is very costly, some of the children are benefited with this therapy also. So I think it might be a last slide for a clinical presentation. Early suspicion of cystic fibrosis is important. In my lectures I repeatedly say cystic fibrosis should be diagnosed in the newborn, then only their life expectancy is drastically improved. So whenever you come across these set of the clinical presentation, particularly the Meconium ileus or neonatal jaundice, Steatorrhea, or very early clubbing, or something like a Pseudo-Bartter syndrome presentation, we have to think of this one. Actually, all the secretions given in the body, anywhere the secretion, it protects the organ. In the mucus, particularly in the airways, plays a major role, and like that the secretion. See, all our enzymes are naturally fluid one, so it becomes very thick. That's a problem happens. The duct get obstructed. That is what happened in the digestive system, particularly pancreas and reproductive system. I think this is the last slide for the clinical symptoms. People who are interested in diagnosis, go and see my second part, that is cystic fibrosis diagnosis. And the third part tells about the treatment. We want to salute this lady, Dorothy Hansen. Actually, she is an American physician. Her observation, why some children are diagnosing very early, and her observation made us a science, and started, and she named the condition as a cystic fibrosis. Then only we started knowing this particular genetic disease, and now world over lot of research is going on cystic fibrosis. Thank you very much.